Well, welcome back. I hope you enjoyed the morning sessions and the afternoon sessions. We are very excited to kick off this next discussion. This morning we talked a lot about history and about historic moments. And for me personally, I consider this a historic moment. Anytime that we are able to bring the directors of the Office of Minority Health together on one stage and just to hear what work is happening across the department. And so we will begin with our discussion, and I hope that you will learn something new today. I'll start by saying welcome to all of you.
Thank you.
So for this segment of the program, we will ask each of the directors to introduce themselves, to tell us a little bit about their office, and then we have a few questions that they'll be answering. I'll start by just introducing myself. As many of you know, my name is Dr. LaShawn McKeever. I'm the director of the CMS Office of Minority Health. And so in my role, I help to oversee the work that is being done through CMS's program, so Medicare, Medicaid, the Marketplace, and CHIP. And I mentioned this morning the populations that we focus on, and today we are here because of our health equity framework that we're implementing and looking at ways that we can do this work across the healthcare system. But I'm really excited to have Rosalind kick us off from HHS. She's with the HHS Office of Minority Health. So if each of you would introduce yourself and then tell us about your office. Thank you.
Well, thank you, first of all, for the opportunity to be here on this panel and then to also be a part of this very special audience. My name is Rosalind Holliday Moore. I am the Deputy Director for Programs at the HHS Office of Minority Health. I am more than delighted to be able to share highlights of our team. We are uniquely positioned within the Department of Health and Human Services and actually all of government with a mission and statutory authority to focus on racial and ethnic minority populations. With that focus, our attention addresses minority health, health disparities, and health equity. When I mention it being unique, is that our mission is really aligned with the social determinants of health and conditions that influence health, but all of it aimed towards racial and ethnic minority populations, which sets us aside from everyone else. Like you, our work also requires partnership and alignment. So we are strategically positioned to align directly with the Office of the Secretary through the Affordable Care Act, but we're also centrally organized so that we connect with the 6 offices of minority health and health disparities, as well as the National Institute for Minority Health and Health Disparities. That creates this amazing infrastructure for focusing on minority health and underserved populations. It also recognizes that much of the work, and arguably the most important work, occurs outside of federal government. So we have the opportunity to support regional minority health analysts in each of the 10 HHS regions. That positions our staff to not only share what we are doing internal to government, but also to leverage the expertise outside of government. The regional minority health analysts work with state partners and community partners to ensure that there's a two-way communication between our team and those outside in communities. So let's think about collaboration as key. It's nice to have partners, it's nice to talk about partnership, but I really believe, and all of us on our team, believe that partnering is the most important, so we're activating it. And I wanted to highlight one program that really crystallizes what we do at the highest level of thinking about the intersections of data, policy, and practice. Those 3 buckets govern all of what we do. We fund demonstration efforts to better understand what's working, what's effective, what's not working, so maybe we stop doing that. And then where are the gaps so that we can close them? The National COVID Resilience Network, managed by Morehouse School of Medicine, was funded by the Office of Minority Health. And I use that as an illustration of how data, policy, and practice have allowed us to establish a network during the greatest challenge that our nation has faced towards health and well-being, to reach over 13.5 million people at the highest risk of poor outcomes from COVID-19. And in their effort, they also established a very unique data set, new and innovative communication strategies, and outlined practices for engaging community members and partners far beyond what we knew at the beginning of the pandemic. So as we're moving forward, we take their accomplishments and celebrate those, but we also have a pathway of new knowledge, new ways of working. And I set that as the stage for this continued conversation because it's that new knowledge that allows us to think about the promotion of health equity in ways that will allow us to seek success that has yet to be witnessed. Thank you very much for your attention.
Well, good afternoon, everyone, and it is an honor and pleasure to be here, and it's just so encouraging to see so many people just interested in equity, and your presence here is just so, fantastic. So I'm Christine Ramey. I am the Deputy Director of the Office of Health Equity at the Health Resources and Services Administration, also known as HRSA. My director, Michelle Allender, sends her regards from a lovely cruise ship in the Mediterranean today. Lucky her. But I'm happy to be here with you all regardless. So I want to start off by talking a little bit about HRSA and who we are, what we do, because sometimes I think people don't necessarily realize some of the programs that HRSA funds. So HRSA is primarily a grant funding agency. We serve tens of millions of Americans through receiving affordable quality health care and other services through our 90+ programs and our more than 3,000 grantees that administer those programs. Our programs at HRSA provide equitable health care to people who are geographically isolated, economically or medically vulnerable. And this includes programs that deliver health services to people with HIV, pregnant people, mothers and their families, those with low incomes, residents of rural areas, American Indians and Alaska Natives, and those otherwise unable to access high-quality health care. HRSA programs support health infrastructure, including through the training of health professionals, as well as we send professionals to where they are needed most. We also provide financial support to healthcare providers and work to advance telehealth. In addition, we oversee programs for providing discounts on prescription drugs to safety net providers, facilitating organ, bone marrow, and cord blood transplantation, as well as compensating individuals injured by vaccination and maintaining data on malpractice payments. So equity is embedded in HRSA's mission, and our mission is to improve health outcomes and achieve health equity through access to quality services, a skilled health workforce, and innovative high-value programs. So now let's share a little bit about our Office of Health Equity. We are kind of similar to the Offices of Minority Health and my colleagues here on the stage. We just call ourselves Office of Health Equity. Our office has actually been around since 1981. And we've been championed through various legislative authorities, the main one, of course, being the passage of the Affordable Care Act. And our office specifically works to reduce health inequalities so that communities and individuals can achieve their highest level of health. And we do this by kind of operating in 4 different areas across HRSA and then also with our external partners. So we serve as the principal advisor regarding health disparities, health equity, health literacy, and minority and priority population health. We provide technical assistance to our internal HRSA bureaus and offices, as well as external groups on matters impacting health equity. We also work to increase the visibility of data and policies that may impact health equity. and then also developing partnerships with other government agencies, such as my colleagues here, as well as other external groups to increase the visibility of health disparities and health equity issues. So part of our technical assistance that we've been providing to our HRSA colleagues is around the subject of health literacy. And health literacy really is a theme that kind of intersects across all of our programs that HRSA has. And to define health literacy, Healthy People 2030 defines it as personal health literacy as the degree to which individuals can have the ability to understand and use information and services to inform health-related decisions and actions for themselves and others, with the ultimate goal of using, for people to use health information rather than just to simply understand it, and then to also make well-informed decisions rather than just simply appropriate ones. So some of our work within our office, we frequently rely on data, program data from our HRSA program offices and also other nationally accessible data sources. And we use this information to help produce national reports on health equity. And our most recent one was the 2019-2020 Health Equity Report, special feature on housing and health inequalities. And keep in mind, when this report was published, it was kind of pre-COVID pandemic, so COVID data was not necessarily available for us to include, but we did see substantial progress nationally for all Americans in various vital indicators, including life expectancy, cardiovascular disease, cancer, and diabetes. But it also highlighted still health inequalities that existed, within population groups and within particular geographic areas. And we noticed substantial disparities are, influenced by social determinants, which included housing. And we did see linkages with a number of health indicators, including infant mortality, chronic obstructive pulmonary disease, kidney disease, Alzheimer's disease, HIV and AIDS, as well as healthcare and access and utilization, disability, mental health, and substance use. So really our work continues within HRSA and through our programs that help deliver quality health care to underserved communities across the country. So that is really our vital focus and our mission, as well as training up and coming health professionals to serve in those areas where there are critical shortages of healthcare providers. So thank you again so much. It's just so great to be here today.
Hi everyone, I'm Tenley Powell-Biggs. I'm the Deputy Director for the Office of Behavioral Health Equity, or OBHE, at the Substance Abuse and Mental Health Services Administration, also known as SAMHSA. SAMHSA is also similar to HRSA, also known as a grant-making agency. We have several centers and offices, 4 of whom focus really on substance abuse treatment, substance abuse prevention, our Center for Mental Health Services, and our Center for Behavioral Health Statistics and Quality. We manage various discretionary grant programs, many I think of whom you all may be familiar with. For example, we have disaster technical assistance centers, we have the trauma-informed schools program. When tragedy strikes and there's mass shootings or natural disasters, we're usually the first ones at the front line. We have staff, we have programs that get created to really focus on addressing the mental health and substance use of those who are suffering from all of these different scenarios and instances. And so, our agency basically touches on everything related to mental health and substance use. So, with COVID, for example, we had to pivot really quickly, just like CMS did with the telehealth, telebehavioral health waivers. Most recently, we have the buprenorphine waivers, so that we're really trying to get access for those who need it without having additional barriers. Within our Office of Behavioral Health Equity, or OB, we do many different things. Our focus is to really help those who are in the underserved, racial, ethnic, sexual and gender minority populations, and also under-resourced populations. And we're really trying to ensure that they get quality care, access to care, and overall positive behavioral health outcomes. So within our office, we have several domains. We focus on policy, We are a policy shop, and so we really try to embed equity throughout all of our programs across SAMHSA. We also have a domain focused on workforce development. As I'm sure many of you know, there's a huge workforce shortage in all of healthcare, but if you look at behavioral health, it's even more dire, and if you look at it from the equity lens, it's even smaller. So we're really trying to develop and build programs around the workforce development piece, and I'll go into that a little bit later when Dr. McGeever asks the other questions. Some other domains that we also have is our communications domain. In case folks don't know, HHS just recently released the language access plan or updated it. So we're really focused on making sure that when it comes to our products, we're really reaching the audiences that are serving those who are underserved. So that's a really, really key part of our work. We also focus on data, because without data, it's really hard to justify why some of these programs are being funded. So we really encourage all of our stakeholders, our grantees, and mostly our community-based organizations, especially those in these under-resourced and underserved areas, because they're the trusted agent. And I think I heard a lot of that in the other breakout sessions, how partnering with the community, they have to be at the table. All those things are really, really key, because without them, we're never gonna be able to really close the gap. I think another piece too that's really unique to SAMHSA as an overall agency, granted, I love all our sister agencies, we're doing incredible work. SAMHSA has been one of the biggest champions of really including people with lived experience. So that means someone who may have had a mental health or substance use disorder, they're living in recovery, they're living in well-being, they're thriving. So we really bring them as part of the fabric of our work, as well as, they're our colleagues, they're our staff members, they're our stakeholders, grantees, et cetera. They help drive the policy that we make. So I think that's something very, very unique. And we also just have established an Office of Recovery. So come September, Recovery Month. Last month in May was Mental Health Awareness Month. And now I'll talk more about the 988 program. I'm hoping folks here are familiar with it. So that's a lot of work, I think, to cover it in like 5 minutes, but I think I'll stop there. Thank you.
Good afternoon, everyone. I'm Rear Admiral Sharday Rojo. I am the Associate Commissioner for Minority Health and Director of the Office of Minority Health and Health Equity at the U.S. Food and Drug Administration, or FDA as we call it. And it is truly an honor and privilege to be here with all of you today. And before I even jump into what we do within FDA's Office of Minority Health and Health Equity, I of course have to look to LaShawn and say thank you so much for hosting this outstanding conference, for all the work you and your team did. So excited to be here. So at FDA, Office of Minority Health and Health Equity, we are actually the first office established at FDA that focused on addressing health disparities. So we're really excited about the work that we get to do every day. And by way of background, our office sits within the Office of the Commissioner. We engage broadly across our agency. We work with a wide range of both public and private sector stakeholders. And we have a dedicated mission focused on protecting and promoting the health of diverse populations through research and outreach and communication that works towards addressing health disparities and, of course, ultimately advancing health equity. And I have to say, like you've heard from everyone here today, collaborations and partnerships are critical for us to achieve our mission. And as you've probably heard, just in highlighting what our mission and the work that we do, we really focus our work in research, outreach, and communication. Of course, we also engage in policy as well. But I really want to take the opportunity today to highlight one of our most recent initiatives that we're so very excited about, and it's a key priority for our office, and that's our Enhance Equity Initiative. This is an initiative that we started only a couple years ago, and it has 3 key components. The first is equity in clinical trials. The second is equitable data efforts, and then lastly, most importantly, equity of voices. And I want to spend some time now talking a little bit about those key areas. Of course, equity in clinical trials is a key priority, long-standing priority for FDA and the Office of Minority Health and Health Equity is advancing diverse participation in clinical trials. We are continuing that work. We have long worked to advance diverse participation. Our agency has hosted public meetings. We've developed tools and resources. We've also issued multiple guidance. And in support of all of the work that's happening across our agency, the Office of Minority Health and Health Equity, we have an ongoing multimedia public education and outreach campaign that works to address some of the barriers preventing diverse groups from participating in clinical trials through a wide range of culturally and linguistically tailored tools, resources, strategies. We have both print and digital health education materials. We have public service announcements. We have a dedicated website with a wide range of resources in multiple languages. And we have ongoing collaborations, partnerships, and of course, wide social media outreach as well. Now, in talking a little bit about our equitable data efforts component, for us, this was a huge area that we were focused on, and we are so very excited. It was actually historic for us. Our office was able to put out our first funding opportunity. We're not a major grant funding organization like some of our sister agencies, but we were very excited to issue our Health Equity Innovation Award. We've actually issued that multiple times now. And through our equitable data efforts, we're really focused on funding research so that we can increase data available in the populations that we serve. Through our funding opportunities, we've been able to engage with a wide range of diverse researchers and scientists, engage with a wide range of organizations and institutions to help to answer pressing health equity focused questions. So that is definitely a priority for us, and we've been really excited about the groups, organizations, and researchers we've been able to work with. And of course, our equity of voices. I think that hearing directly from the community is critically important. So within our equity of voices aim, we are focused on ensuring that we are always and continuously understanding diverse patient perspectives, preferences, and unmet needs to inform the work that we do. We actually kicked off, which we were really excited about. We were able to work with a group of diverse individuals, and we were able to capture their stories. They are living with HIV, and they highlighted their journey as well as their experience with antiretroviral treatment. And we have that video series available as part of our Equity of Voices effort on our website. So we were very excited on that work, as well as the research we've been able to fund so that we can continue to understand ways and new and innovative ways to engage with diverse communities. And of course, you know, I have to end with kind of thinking about the future. An area for us that we know is so important is being able to continue to support the next generation of those that are going to be focused on carrying out health equity focused work. One of the ways in which we do that is through internships and fellowships. And we've been really fortunate to be able to partner with the National Human Genome Research Institute at NIH, and we have a joint postdoctoral fellowship that is focused on genomic science and health equity. And this is a 3-year fellowship, and they have a unique opportunity to be able to have a mentor not only at NIH, but also at FDA. And it's really provided an opportunity for us to be able to continue to support those who are doing work related to health equity. And with that, I will say, of course, I have to put the plug in for all of the resources and information I just shared. You can find all of that on our fda.gov/health equity website. So thank you so much.
Good afternoon, everyone. It's an honor to be a part of this panel this afternoon. My name is Keisha Koa, and I'm the Director of the Division of Priority Populations at the Agency for Healthcare Research and Quality, also known as AHRQ. And AHRQ is the lead federal agency tasked with improving the safety and quality of healthcare for all Americans. And so our mission is to produce evidence to make healthcare safer, higher quality, more accessible, equitable, and affordable. And work with our partners within HHS and external to HHS just to make sure that the information is not only produced, but it's understood and it's used to really transform healthcare. So organizationally, the Division of Priority Populations sits in the Office of Extramural Research, Education, and Priority Populations. And our division really, so health equity is sort of embedded within the agency. It really is an agency-wide focus. So there's activities related to health equity going on throughout AHRQ. There's our division really monitors that and makes sure that we're sort of making the impact that we're supposed to, and of course contributes to those activities as well. We have 3 core competencies, and those really structure the activities that we undertake in the health equity space. And our core competencies are health systems research, practice improvement, and data and analytics. And I'm going to talk a little bit about each of those competencies. So for health system research, AHRQ both funds health services and health systems research, and we conduct research internally. And recently, we've had several notice of funding opportunities related to health disparities and health equity. And we recently published a special emphasis notice announcing ARC's interest in health equity-focused health systems research. And so we're continuing to identify ways to fund that research externally and also conduct the research internally. And I can talk a little bit more about that as the panel goes on. Practice improvement is a really important part of what we do. So like I said, we do want to produce the information. We're a research organization, but we want to make sure it's used. So dissemination and implementation are really important. And so in addition to sort of conducting research, we also develop, test, and share resources and strategies that health systems and clinicians can use to improve the quality of the healthcare that they're delivering. And that's an important part of what we do. And finally, this has come up a couple times, but data and analytics are really important to make sure we're sort of understanding our baseline, the impact of our different efforts, and really can monitor that over time. And so we generate various measures and data that can be used by policymakers, providers, health system representatives across the board to really inform the healthcare system. So we produce, along with HHS partners, the National Healthcare Quality and Disparities Report annually, which has hundreds of health quality measures and indicates where disparities exist. We also have data efforts to both collate and also identify areas where we're collecting data on social determinants of health, so that can be used both internally and externally by researchers. And finally, we collect racial and ethnic data in all of our major research programs. So ARC is a smaller agency, so not everyone's familiar with ARC, but sometimes folks are familiar with some of our data sets, so like the Healthcare Cost and Utilization Project and the Medical Expenditures Panel Survey. So that is publicly available so that health services researchers can use that to really inform their work. So I'm going to stop there just so we can dig into the questions.
Okay, yes. So thank you all for those comments, and I like to refer to the directors of the offices of minority health as the champions for this work across the department, because our offices are often leading the strategies that are driving this work, and we discussed this morning that this work can be hard, but as Rear Admiral Levine said today, or Admiral Levine said today, approaching it from a positive attitude, we never give up, and we're always looking to advance health equity. With that, we're going to have a few questions for each of you respectively. And I asked if our screens can be turned on down here. They're off for us, if we can turn those on. The first one is for Rosalind from HHS OMH. What resources does OMH have that can help organizations with practices and innovative solutions and allow them to collaborate on community engagement efforts?
Well, thank you for the question, first of all. And second of all, it's one of my favorites because it's our opportunity to be helpful, which is always the aim. We have a congressional mandate to establish a resource center, and that resource center is functioning around the value and importance we recognize for engaging community partners and other groups that are interested in promoting minority health and health equity. So our Office of Minority Health Resource Center, which everyone can access easily, serves as a public-facing repository for all information related to minority health. But in addition to that, it includes a knowledge center that serves as the nation's library for minority health and health disparities. It's an interactive resource so that if you have questions or ways in which we can support you in better understanding the questions that you'd like to have answered, or ways in which we can understand the questions you are answering, that knowledge center is front and center. Additionally, we have a Minority Health Social Vulnerability Index. I raise this because you heard me earlier talk about the value of data, policy, and practice. So our resource center supports practice in a very broad way as well as a narrow way, but the data is also important. With our Minority Health Social Vulnerability Index, we encourage you not only to use it to better understand vulnerabilities where you sit, but also to help us understand the utility of the tool. So again, it's a two-way exchange of information sharing and knowledge building. And last, definitely not least, is our Think Cultural Health website, which is an amazing repository of both factual information around the national class standards, but also the e-learning program library. I want everyone in this audience beyond, whether you're in the room or in the virtual space, to please leverage that tool, not only to help expand your individual competency in promoting cultural and linguistic appropriate care, but also in ensuring that your partners are also able to advance the work in that area. So thank you very much for the question, and definitely thank you for engaging with our resources.
Yes. And you all have amazing resources that I've leveraged myself, so I can testify to that. This next question is for Tinley from SAMHSA. What does the equity environment look like for mental health and substance use, and how is your office addressing disparities in these areas?
Yes, so I want to start by saying that SAMHSA just celebrated its 30th anniversary last year. We were created in 1992, and I say this because despite decades of research, policy discussions, convenings of experts and advocates, healthcare reform efforts, disparities in behavioral health for underserved, historically marginalized populations continue to persist. Healthcare policies have not resolved the lack of insurance or underinsurance for these populations. We still are, seeing linguistic and cultural barriers. There's stigmatized pathways to care. When you think about evidence-based practices that are out there and available, they're not always culturally adapted or culturally acceptable. And we're also still seeing a lack of diversity in the workforce. When you look at SAMHSA's National Survey of Drug Use and Health, or NSDUH, NSDUH, we just recently released the report that covers the 2021 data, so it does cover the COVID piece, but it's now available by race and ethnicity. And when you look at that data and you look at mental health post-COVID, unfortunately there has been increases in terms of mental health issues and problems, specifically around suicide rates. If you look at Black youth and adolescents, there's alarming spikes in suicide rates. When you look at Latina adolescents, there is also increased rates of suicidal ideation. The continuing high rates of suicide among American Indian, Alaska Native still continues. And then, again, there's just so much work to do in this space. When we take a look at the substance use side, post-COVID, just over the last year, we still have over 100,000 opioid deaths, mainly due to fentanyl. And it also, even though right now it's plateauing for the general population, we're still seeing tremendous disparities, specifically among Black and Hispanic communities. And when you look at these communities at treatment outcomes, treatment retention, those rates are not great. So, despite these numbers, I do want to say that our office is doing many different things to try and address them. Due to time, I'm going to just cover a couple of them. One of them is our Disparity Impact Statement and Strategy, or DIS. And to come full circle, I also actually worked at CMS for Dr. LaShawn McKeever. So we also did the DIS there too. I'm sure many of you here in the audience are familiar. We call it the Disparity Impact Statement, but maybe you look at it as like the Health Equity Impact Assessment, right? Like everybody has a different one of calling it. But it's really key because this is a data-driven, incentive funded initiative where we basically ask our discretionary grantees to tell us what interventions, whether it's outreach and engagement, what actual activities are you implementing in mental health and substance use that is addressing a disparity. We've been doing this work for the past decade. We're actually revising it. We added SDOH, so now they have to report on that, which is really exciting. So that's one of our policies. We're also proposing to create a data management system that's integrated that we can then come up with like data dashboards and really look at behavioral health activities to see, are we closing the gap? Another initiative that we have is our Centers of Excellence. We have funded several centers of excellence focused on specific populations. The Center of Excellence for African American in Behavioral Health is actually managed by the Morehouse School of Medicine. We also have the LGBTQ, we call them COE, Centers of Excellence. That's managed by University of Connecticut. And then we have the Ohana Center for the Asian American Native Hawaiian Pacific Islander Center of Excellence based out of the Department of Behavioral Health in Hawaii. And then we're going to fund a Hispanic Latino COE sometime this fall. And then out of our Office of Tribal Affairs and Policy, they're going to be funding a new Center of Excellence for American Indian Alaska Native. We're really hoping to use these centers of excellence to increase workforce infrastructure and service capacity. Another initiative that we have is something called Elevating Community-Based Organizations, or CBOs. And I think, honestly, this is the bread and butter of the work that we do, both within OB, I think, across all of our departments, where we're really trying to look at how do we get the community voice to the table. Oftentimes, based on the way Congress appropriates our dollars, a lot of the funding, and it should, they go to states, right? But by the time the states get it and trickle down to the communities, is it going to the right places? Are they looking at where those underserved areas are, right? And sometimes people are looking at it from the business side, which is fine, but those folks kind of fall through the gaps. And so we're really hoping to elevate this initiative. We're getting different pilots and trainings out there to really help those CBOs come to the table and actually be competitive in federal funds. Because oftentimes they say, you don't know who we are, we're doing all this work, can you please help us? And so we're really paying attention to that. There is, just recently, it's going to close tomorrow, we have a Behavioral Health Equity Challenge. You can find us on challenge.gov. We're going to award $50,000 to each recipient. There's going to be 10 winners. It's not a grant. It's basically saying, hey, what have you done to do phenomenal, innovative outreach and engagement strategies to these racial and ethnic underserved communities? And then we will give you time to be recognized in front of SAMHSA and the nation. So that's really exciting. So please, take a look at that. We have an amazing team who's been working on it. So hopefully we'll get really good information about that. And then lastly, I want to say about embedding equity into our 988 and our Certified Community Behavioral Health Clinics, or CCBHCs. The 988 was launched last July. It's supposed to replace 911. So if you know someone who's in crisis, who is thinking about hurting themselves, or you have a family member who's concerned, they can call, they can text. It's available in English. The language line is available in Spanish. If you're from the LGBTQ plus community and you want to talk to somebody, there's an option for that, as well as for veterans and service members. And then we have the CCBHCs, which we actually partnered with CMS to do the state demonstration pilot, and we're still continuing to work with CMS because the CCBHCs, the Certified Community Behavioral Health Clinics, is integrating both mental health and substance use in one setting. We are actually hoping to mirror our HRSA FQHC program, the Federally Qualified Health Centers, so lots to come in that space. Thank you.
Thank you. Thank you. And thank you for highlighting collaboration. So I tried to drop a subtle hint this morning that one of the themes is collaboration. We can't do this work alone. And we collaborate as federal agencies in this space, and we've been able to do amazing things together. So this next question is for Christine from HRSA. You gave us a brief overview earlier, but we wanted you to briefly describe the work done within HRSA's Office of Minority Health Equity in a little more detail. And in particular, are there any projects that your office is engaged in that would be of interest to these attendees today?
Well, thank you for that question. Yeah, there are a few projects that we sort of have going on, and one big initiative I think that's sort of been, a big priority for our Administrator Carol Johnson is really getting more outreach to communities, and especially community-based organizations in particular that may not necessarily have had a lot of familiarity with HRSA, or maybe aren't necessarily have the capacity to apply for a grant. And this is also sort of based on feedback that we've gotten, also just kind of talking with other external partners. So one focus that our office is really looking at doing is sort of leveraging and also trying to work with historically black colleges and universities, so it's not lost on me here that we're at Howard today, which is an HBCU, as well as also tribal colleges and universities and other minority serving institutions. And really what we're looking to do is help provide information on upcoming funding opportunities I think, our thought in HRSA is that a lot of these institutions of higher education often serve underserved communities through their graduates, and we really feel like having representation from HBCUs, tribal colleges and universities, and other minority serving institutions really can help kind of get the message out there and also help get resources where they're needed most. So we've been, within our office specifically, we've been working on kind of trying to enhance our communication about funding opportunities that are available. We also have a quarterly e-bulletin that we produce out of our office where we kind of highlight various HRSA programs. We often highlight our Bureau of Health Workforce because a lot of it does kind of lend itself well to HBCUs and other minority serving institutions. In addition, we've also been looking at ways that we can provide more technical assistance to these eligible groups to help them, be aware of what funding opportunities are available, how they can access some of this technical assistance to help them better understand exactly what is this funding opportunity asking for. But we're also continuing to work in looking at getting diverse representation for our grant review panels. We really feel like the input of the communities is so invaluable to our HRSA program offices, and also, having voices from HBCUs and other minority serving institutions is just incredibly helpful because a lot of times they have a lot of lived experience as well as subject matter expertise that they bring to the table. And then also really by becoming a grant reviewer, it also helps them better understand the process of how HRSA evaluates our grants and how those decisions are made on who gets awarded funding. So that's us in a nutshell.
All right, thank you for that additional information. This next question is for Keisha from ARC. So in the beginning, you gave us an overview, but I wanted you to focus on which area do you think ARC has made a unique contribution that supports the HHS-wide focus on advancing health equity?
Sure. Yeah, before I answer that question, we're also looking for diverse grant reviewers. So ARC also has study sections, and if there's people who are interested, we're always looking to diversify. So I just want to throw that out there too. But one area which I mentioned before, I really think it's in the practice improvement area, and the resources that we develop. And so related to equity, we know that there are persistent maternal health inequities, and this is a priority for ARC, for HHS, and for the Biden-Harris administration. And we have a toolkit, a program called the Safety Program for Perinatal Care that's been around for a while. And it's a toolkit to help improve the patient safety culture of labor and delivery units. And really what the goal is to decrease the number of maternal and neonatal adverse events. And the program's designed around 3 pillars: teamwork and communication skills, perinatal safety strategies, and in situ simulation training. And it really builds off previous ARC toolkits that are really well tested and embedded in areas around, again, safety and teamwork. And these toolkits can be customized to the local unit, procedures and processes. So we really want these to be widely used to really have an impact and sort of understand how they're being used and adapted to change practice delivery. We're actually starting a new phase where we're updating this tool, and this phase has an explicit equity lens. So it's trying to embed respectful maternity care into the toolkit. And so currently, we're working on a systematic review of respectful maternity care and evidence synthesis review, where we're defining what that means, its components, measures and tools that are available to both assess and implement a respectful and safe care. And we're really going to use the findings from that evidence synthesis review to figure out how to best embed this into the toolkit to improve the toolkit.
Okay, thank you for that information. Okay, so our final agency-specific question goes to Rear Admiral Araujo. We know that your office focuses quite a bit on clinical trial strategies to improve participant diversity. Is there a commonly held misconception that most of us are getting wrong about clinical trials as it relates to racial and ethnic minority populations?
That's a very good question. I think that there are a number of misconceptions. One that we hear all too often is really the misconception that racial and ethnic minority populations do not want to participate in clinical trials. And that is something that we hear quite often, and because of that misconception, oftentimes they aren't asked to participate and they aren't offered opportunities to participate. However, we know that that's not always the case. I talked a little bit before about our campaign and education, and with that campaign, we are not only working to educate potential participants in clinical trials, but we also want to be able to educate the broader clinical research enterprise and really highlight for them the importance of finding ways to convey the availability of research opportunities. Another area for us that's really important is making sure that we have those resources available that highlight what a clinical trial is, what it means to participate. I mentioned some of the resources we have available in multiple languages, and we also know that I think the other area that has been really important is that we know clinician recommendations for patients on whether about participating in clinical trials is also really important. So we definitely also encourage engagement with community providers when we think about clinical research. And I'll also mention, just more generally, I talked about, we talked a lot about clinical trial diversity and education around that, but we also have an online catalog within the Office of Minority Health and Health Equity's website that provides a wide range of resources related to various diseases and conditions. The goal of that catalog is really to be able to educate on the FDA-regulated products so that consumers can make informed decisions about their health. And across all of those resources, we also include information about where you can learn more about clinical trials. And again, those resources are provided in multiple languages.
Okay, thank you. Thank you. So the theme of our conference is Framing the Future of Equitable Healthcare. And we only have a few short minutes. I had many more questions for them, so they're getting off the hook today. But I think it's important for this audience to hear from our offices about what we're excited for in the future. Our health equity framework is a 10-year framework. So we, in the next few years, we are excited to see the advances that we will make as an agency as it relates to data collection, as it relates to our agency intentionally understanding where there may be health inequities in our programs. There are 5 things that we're focused on, and I'm very excited that we're not alone in this work. As I've traveled the country and I've talked to many of you, you've shared how you're doing things that span these priorities. And so, I want the audience to hear from you all and about what you're excited about. We only have a few minutes, so maybe if you can each take a minute or so to close us out with, what message or what you're most excited about.
Sorry.
Well, I'll let Rosalind off the hook this time. We'll start with you.
Okay. I just feel like it's an exciting time where there's a lot of passion and also some resources available to really make an impact. I'm going to sound like a record because this has come up multiple times, but I think the partnership building is such an important part of it. So really continuing the existing partnerships, but really thinking inclusively and broadly about other sectors that we can partner with to really have a bigger impact. And so thinking about people like in the transportation sector or education sector, housing, because we know that all of these have a really big impact on health, probably even bigger than sort of people's engagement with the healthcare system. And so working collaboratively with these sectors is really going to help benefit from the unique contributions of each and really allow us to make a bigger impact than we could on our own. So I think that's what I'm most excited about, potential partnership building.
Okay.
And it's so hard to say one thing, but I think also I agree that right now there's so much momentum and attention and focus on health equity, which is so exciting. And so I think one of the things that I look forward to is for that to continue. So being able to continue to support and provide training for those who are dedicated and focused on working in the space of addressing health disparities and advancing health equity is something that I think is critically important and that we should continue. I mentioned how we do that with internships and fellowships, and I also think that helps us to grow the diversity of our workforce as well.
Yes, I think to add to that, there's just so many things we can focus on, and I think it's almost like the time is now, right? I feel like someone keeps saying that over and over again, but I think when it comes to equity, with all the executive orders that we have in place, I think almost every office here, we are all doing our best to cement the work, to make it sustainable, to build it in so that as things change, because things will change, we're hoping that this stays. With SAMHSA, our strategic plan that just got released, not the OBHE one, but the SAMHSA overall, equity is one of our core principles. So again, we're really hoping in the 5-year long-term plan that this will stay. In terms of the work that you all are doing, that we're doing here as well, my hope is that we continue to be data-informed, data-driven, really thinking about centering at the margins, again, looking at who's not at the table, and then also making sure that they have a voice at that table, looking and ensuring that community is part of this process. So, thank you.
I think for me, and probably many of my colleagues at HRSA as well, it's just such a fundamental time, I think, for us to capitalize on this opportunity that we have before us. At HRSA, really, we've been sort of looking at kind of a holistic approach to equity, and really we've been really focused in on our funding opportunities and looking at how can we make those more equitable and accessible to more individuals and smaller community-based organizations as well. I think it's critically important to really get the voices of the communities that are being served by our HRSA programs and making sure that we have adequate representation and members of those communities that are receiving funding. We've made a few changes internally to sort of help with that process as we write notices of funding opportunities that'll go out publicly. And so hopefully our goal is within the next year and a few subsequent years going forward is to collect some information from those groups to see what's working for them. Has anything changed? Is it better? Is it worse? Is it still the same? So I really think there's just such a great opportunity, and it seems like there's really just a very intentional whole of government approach to equity, not just within HHS itself. So it's exciting.
So hopefully not least, this is an unprecedented time. We know more, we have done more for people who have not received help for decades. We know that the need continues, and we know that we are committed as a nation for doing better. If now is not the time to be excited, I don't think it will ever arrive.
What powerful words to conclude our session. I'd like, just if you all can help me thank our wonderful panelists one more time for their time today.
Thank you.
So with that, it concludes this session. We will have a 15-minute break, and then we will convene to hear about the CMS maternal health strategy. Thank you so much.
Did you still want to do